I'm Luke Walker.
And I'm Dr. Kathy Frida Bailey.
And we're here with the West Virginia Autism Training Center at Marshall University to talk about one of the topics that our families bring up again and again and again, and that's dual diagnoses with autism.
So today we want you to learn about the existing literature on dual diagnoses conditions with ASD based on the DSM-5 diagnostic criteria. That's the Diagnostic and Statistical Manual of Mental Disorders, which is what psychologists use to diagnose individuals. We want you to become familiar with best practices in differential diagnoses, and then learn about some evidence-based treatment techniques, so what we know works. In terms of dual diagnoses, we know that approximately 70% of individuals with ASD have at least one additional psychiatric disorder. The most common are social anxiety, ADHD, attention deficit hyperactivity disorder, and oppositional defiant disorder. And we'll talk more about that in a minute and some of the trickiness there. So why is identification of dual diagnoses important? In practice, interventions can be targeted based on these co-occurring conditions, and ultimately that can improve the quality of life for the individual. In research, improved identification can shed light on some underlying biological processes, but ultimately identification and treatment of these disorders and symptoms substantially improves the quality of life for these individuals. So when should we consider dual diagnoses? They might be considered when the individual shows signs of difficulties outside of autism spectrum disorder, or even a worsening of symptoms that don't respond as expected to treatment. Other considerations include significant changes from typical, or we call it baseline symptoms, what's typical for that individual, behaviors that are severe or incapacitating for the individual, and then failure to respond as expected to empirically based interventions, so interventions that we know generally work in practice. So now I'm going to talk a little bit more in depth about some common dual diagnoses. So ADHD, I'm sure you hear that a lot with your clients, Luke.
That's probably the most common, is our ADHD.
It is, absolutely. Anxiety and mood disorders is probably the second most common. Intellectual disability, which is highly controversial, and I'm going to talk about why. Learning disorders, and medical issues.
And I see, well, maybe I should talk about this later.
No, go ahead.
But I see anxiety and mood disorders especially more prevalent with our older kids that we
Absolutely,
work with.
as they're starting to become more self-aware and self-conscious of maybe some potential differences in interpreting the world, and that can result in some anxiety for sure. So first, autism and ADHD. This is one of the most prevalent and also controversial dual diagnoses. There's definitely a debate among professionals about ADHD comorbidity rates in ASD, but research generally suggests dual diagnosis rates are as high as 50%. So basically that's a fancy way of saying that 50% of individuals with autism spectrum disorder could potentially qualify for an additional ADHD diagnosis. However, it's important to note that these symptoms often overlap with ADHD. So in this particular study by Sturm et al., they looked at a sample of 100 children with high-functioning ASD, what we previously would call Asperger's disorder. And of all of those students, 95% had attention difficulties. Wow. 75% had motor difficulties, and 86% struggled to regulate their activity levels. So basically the take-home message here is 3/4 of those kids with ASD had symptoms that were compatible with mild to severe ADHD. But what we need to think about is it worth making an additional diagnosis? What's the benefit to that individual? So this chart is a differential of autism spectrum disorder versus ADHD. So in individuals with ASD and ADHD, we see some commonalities in difficulties with nonverbal communication, social interactions, language, and stereotyped interests. Although there's a lot of overlap in the symptoms of autism spectrum disorder and ADHD, there are definitely some significant differences that are worth pointing out.
Absolutely.
So first, nonverbal communication. Individuals with autism tend to have limited eye contact. They might not direct their facial expressions to others. So if I'm talking to you, Luke, I might direct my smile at the top of the ceiling.
Yeah.
But potential ADHD will have difficulties with personal space, where they don't have that imaginary bubble and don't understand that. Which is also sometimes true for individuals with autism, so it can get very, very tricky in diagnoses. In terms of social interactions, individuals with autism tend to seek friends based on their personal interests. So-and-so is my friend because they also like this, like I do. Individuals with potential ADHD may be more likely to make friends but then lose them quickly because they don't have those same reciprocal friendship skills.
I would say that child with autism too will try and make friendships based on, I really like trains, let's find someone else who likes trains. Or I really like washing machines. I'm only going to talk to people who like washing machines. Like
right,
me.
exactly. Because I like washing machines, I think everybody else likes washing machines.
Right, yeah.
Definitely. In terms of language, individuals with ASD may have a history of delayed or immediate echolalia. And echolalia is just a fancy word of saying, repeating things that other people say, or even scripting things that they've heard on television shows. Individuals with ADHD don't have that. Not to say that every individual with autism does do that, but that's generally indicative of ASD. Individuals with ADHD, in turn, might talk excessively with no reciprocity in conversation. And again, I've said this a few times, that's also typical of individuals with ASD. So you can see how there's really a gray area right there where you have to look at every individual case and what's the best for that individual child.
Definitely a lot of overlap between the two.
Absolutely. And then finally, stereotyped interest. So individuals with ASD might talk repetitively about facts in their perceptive area of interest. Individuals with potential ADHD might play video games for hours on end to maintain that level of stimulation that they need. So now I'm going to talk about autism and oppositional defiant disorder. And this is one that's very controversial because to be truly diagnosed with ODD, it has to include a certain degree of, number one, vindictiveness. So knowledge that what they're doing is going to hurt the other individual.
Right.
Awareness that the behavior is disruptive, and then anger or resentfulness. However, our friends with ASD might not have that self-awareness that the behavior is disruptive. So is an ODD diagnosis ever warranted? And sometimes it might be due to a lack of understanding of behavioral expectations. Individuals with ASD are actually more likely to engage in oppositional behaviors as a response to environmental stressors, such as academic or social stressors, rather than vindictiveness per se. So it's important to note that as a parent, caregiver, teacher, mental health professional.
It just seems to be really important that there's this awareness that the behavior is going to be disruptful.
Right, exactly. And there's definitely some controversy about whether or not that exists. So. Next, autism and depression. I'll talk about some internalizing disorders. Depression is one of the most common co-occurring syndromes that's been observed in individuals with ASD, particularly in individuals who are highly verbal. An evaluation of psychiatric comorbidity, so another fancy way of saying dual diagnoses, in young adults with autism revealed that 70% had experienced at least one episode of major depression. So, more severe ASD symptoms may change the typical depression profile. So for all of these diagnoses, they can look very different in individuals with ASD. But identification is particularly imperative for individuals with depression and ASD. Individuals who have ASD and co-occurring depression experience a greater risk of suicidal ideation, withdrawal from peers and family members, and aggression too.
So you can see how important it is to get these diagnoses right.
Definitely.
And spot these signs of depression in advance.
Absolutely. About 50% of individuals with ASD exhibit co-occurring anxiety symptoms that are significant enough to disrupt their daily functioning. So that's really the litmus test there. Is it enough to disrupt their daily functioning? Anxiety disorders are definitely easier to identify and treat in individuals who are highly verbal because they can articulate their emotions.
Right, yeah.
Another documented association is with obsessive compulsive disorder called OCD. Individuals with OCD and ASD both engage in repetitive acts to reduce anxiety, but there's some significant differences that I want to point out here. It's difficult to determine sometimes whether an observed obsessive/repetitive behavior is an expression of a separate dual OCD or actually an integral part of the core symptoms of ASD. So according to this study that came out in 2007, there are 3 factors that need to be present for an additional OCD diagnosis. So number 1, the acts need to be typical for individuals with OCD. So for example, one that's very typical is excessive hand washing to kill germs. Number 2, interventions that are typically effective for individuals with OCD are effective. So it makes sense, if you're treating OCD, if the interventions are effective. And then finally, the core OCD symptoms are beyond what we consider stereotyped or repetitive behaviors for individuals with ASD. However, unfortunately, these criteria haven't been tested empirically to date, so we don't know for sure if this is the case. It's kind of more of a hypothesis. So I want to talk a little bit about the differences between autism spectrum disorder and obsessive compulsive disorder. So first, in terms of communication, individuals with autism spectrum disorder may engage in delayed or immediate echolalia. Do you remember what I said echolalia was, Luke?
Just repeating.
Yes, I know.
Over and over.
I know you know. Potential OCD is repetitive reassurance, seeking from parents or friends They might say certain words until it feels just right. In terms of routines, individuals with ASD generally have a need for sameness and predictability in routine. It's comforting for them. We call that egosyntonic. For individuals with obsessive compulsive disorder, these compulsions follow themes and are distressing to the individual, which we call ego-dystonic. So the key there is for the individuals with ASD, these routines are comforting, and for the individuals with OCD, it can be distressing to them to do them. So that's really the number one sign right there. And then finally, preoccupation with parts. So individuals with ASD might be engaged by moving parts or reflective surfaces. So they might pick up a car and look at it from a certain angle from their eyes. Yeah. Individuals with OCD might avoid objects with certain characteristics because it's highly aversive to them.
And I say the most that I see with my parents when they talk about kids that have the OCD behaviors, they're talking about doing those repetitive activities to help them soothe and self-soothe, and they seem calmed down and they seem at their much laid back when they're doing those.
Exactly.
So that's an important distinction.
Right, so that would be indicative of their ASD and not really go beyond that realm. Yeah. Okay, now we're going to talk about intellectual disability. Previously, intellectual disability and dual diagnosis with ASD was highly overestimated. They previously estimated that about 75% of individuals had an intellectual disability with ASD. We define that by an IQ intelligent quotient 70 or under with significant impairments in adaptive functioning. So adaptive functioning is basic health, self-help skills, social skills, things like that. However, we know that cognitive assessment for individuals with autism is very debated, and there's really limited empirical evidence that it's as effective and valid for individuals with ASD. Previous research indicates that something we call the performance IQ is typically higher than the individual's verbal abilities, which can raise some really significant validity concerns, and good practitioners will interpret these with definitely a grain of salt. And looking at the bigger picture, so looking at all sources of information. Many individuals with ASD also have adaptive behavior delays, even with high cognitive ability. So we might have an individual who has an IQ of 130, but then has significant difficulties with self-help skills, adaptive skills, and so forth.
Right.
In terms of learning disorders, autism spectrum disorder is often exclusionary criteria for a reading disorder diagnosis, such as dyslexia. But individuals with dyslexia often struggle with those same pragmatic language impairments that our children with ASD do. So these can include difficulties making inferences from a story, choosing a punchline for jokes, things like that, being very literal in their thinking. And this can definitely have significant implications for written language and social interactions, understanding when others are teasing, sarcasm.
Right, yeah, or just being able to understand the point of somebody's story, or if someone's making fun of them.
Mm-hmm, yeah, definitely. Tourette syndrome and tic disorders. They might present as a comorbid or dual condition in up to 22% of children with ASD based on estimates. But there are some distinguishing characteristics here between tics and what we call stereotyped movements in individuals with ASD, and this is really important for diagnosis as well. So first, tics are usually single and random. They usually involve the face, the neck, shoulders. They might be temporarily suppressible. So sometimes individuals with Tourette's disorder will hold in their tics all day long, and then when they come home, they just let it all out in their safe space. Stereotyped movements, in contrast for individuals with ASD, are more rhythmic and serve as kind of a soothing mechanism. They involve the whole body sometimes, hands, fingers, and they might help to meet sensory needs. So it's helpful to that individual. I'll pull up a chart here that kind of shows the differences between stereotyped movements versus tic disorders. So for stereotyped movements, individuals with ASD, they might involve the whole body, hands or fingers. Individuals with tic disorders or Tourette syndrome, the tics usually involve the face, neck, and shoulders. For individuals with ASD, the movements help to meet their sensory needs. It can be soothing for them. For individuals with Tourette's disorder or tic disorders, the tics are generally involuntary, but they might be temporarily suppressible. Then finally, stereotyped movements for individuals with autism are more rhythmic in nature. And for individuals with tic disorder or Tourette's, the tics occur repeatedly, but they typically don't have a particular rhythm.
Yeah, when I see some of the kids that I work with their stereotyped movements, it's definitely like a pattern to it. It's the same repetitive kind of movements,
right?
And there's a whole routine that they go through, and it does usually involve the whole body,
right? And it's voluntary in nature.
Right. Yeah, it seems like they're enjoying it, or it's calming for them.
Particularly during experiences or times of the day that can be very aversive or overstimulating to them, it can kind of serve as a soothing mechanism. All right. Now we'll talk a bit about schizophrenia. ASD was initially believed to be an early manifestation of schizophrenia, and in 1971 it was separated conceptually based on a variety of differences, such as age of onset, absence of hallucinations and delusions, and response to treatment. However, individuals with ASD might present with what we call negative symptoms, so flat affect or lack of responsiveness, that could lead to a misdiagnosis of schizophrenia and other psychotic disorders, which can be a problem for sure. So I'm going to pull up in the DSM-5, the manual that psychologists use to diagnose individuals, called the Diagnostic and Statistical Manual of Mental Disorders. They state that if there's a history of autism spectrum disorder or other communication disorder of childhood onset, an additional diagnosis of schizophrenia is made only if the prominent delusions or hallucinations are also present for at least 1 month, or less if successfully treated.
So I've noticed with some of the families that I work with, they'll talk about their child, their daughter, who will talk to somebody who isn't there, or they will act out a script, and it's almost as if you could say, there were these hallucinations, but it seems to be much more to me like it's their sensory needs, or they're just replaying a social situation in their mind.
Right, exactly. More replaying it versus actually visualizing somebody there or hearing somebody there. Just replaying it. Exactly, yeah. In terms of medical conditions, individuals with ASD are more susceptible to have some significant medical concerns. So, according to the CDC, children with ASD have much higher than expected rates of a variety of medical conditions, including eczema, allergies, asthma, ear and respiratory infections, gastrointestinal problems, severe headaches, migraines, and seizures. Epilepsy is also a huge one. There are a lot of challenges when we're considering making dual diagnosis, and we've kind of touched on some of these already, but I want to talk about that a little bit more in depth. So first and foremost is communication. Even highly verbal individuals with ASD might have difficulty with what we call the theory of the mind, so understanding what others are thinking, empathy, and then especially articulating their emotions and experiences. Also, we want to consider something called diagnostic overshadowing. Secondary disorders might be overshadowed by ASD symptoms, such as depression, for example. The ASD might be so prominent that you won't see that individual is also suffering from depression or even suicidal ideation. So it's very, very important to consider every individual as an individual. Differences in presentation. Presentation of psychiatric illnesses might be vastly different in individuals with ASD. They may have a different topography. Even though overlapping clinical symptoms can make diagnosis challenging, identifying these complex individual needs can result in more effective interventions and ultimately improve quality of life for that child. So for example, I thought this was interesting. In this study that came out in 2014, 6 to 21% of individuals with ASD experienced co-occurring bipolar disorder. So typical symptoms for bipolar disorder in adolescence can include irritability, dysphoric mood, hostility, restlessness, and aggression. But individuals with ASD and comorbid bipolar disorder are more likely to experience euphoria, elation, and jocularity. So it's just one example of where it can look different sometimes, but not always.
And that sounds like it'd be really difficult to diagnose some of those.
It is, absolutely, and it definitely requires, multiple sources of information and getting to know that individual.
Really working as a team.
Right, yes. Absolutely. I really like this quote. So treatment of comorbid medical conditions may result in a substantial improvement of quality of life for both the child and their parents. What investigations should be implemented can vary both within the autism spectrum and individually. In terms of treatment methods, studies of psychosocial and behavioral treatment effectiveness are definitely complicated for all populations, but particularly for children with ASD. So therapy and educational models might be used to treat the core symptoms of ASD, such as ABA-based therapies. Many psychosocial treatments are communication-based, which we know can be less effective for individuals with ASD. However, there is some promising research about cognitive behavioral therapy. Growing literature supports the benefits of, we call it CBT, especially for highly verbal individuals with ASD. In 2015, a researcher named conducted a meta-analysis of 14 studies. So meta-analysis is when you take a variety of studies and kind of lump them all together to see if there are effects. They included 511 youth with high-functioning ASD receiving CBT, so it's a pretty big study, and they saw some statistically significant difference with treatment effects. So basically, CBT did work for those individuals, which is very exciting, very promising. We get asked a lot about medication. As we know, there's no standard medication to treat the core symptoms of autism. However, medications might be used to treat co-occurring psychiatric symptoms within the context of ASD. Risperidone is empirically supported for treatment of stereotypes associated with ASD, as well as comorbid tic disorder or Tourette syndrome. Methylphenidate has lower response rates for treating inattention and hyperactivity in children with ASD, but it's still considered effective. Studies on amphetamines for children with ASD and ADHD are lacking. And then finally, empirical data supports the use of SSRIs, selective serotonin reuptake inhibitors, and serotonin norepinephrine reuptake inhibitors to treat co-occurring depression with ASD.
It sounds like there are some treatment options out there with medication,
right?
But there's still further studies that need to be done.
Exactly, and I think the important thing to note, and I think that anyone prescribing this would know that, is that they might react differently in individuals with ASD, so closely monitoring that individual is incredibly important.
Yeah.
So in conclusion, we need empirically validated evaluation tools for identifying comorbidity with ASD. Ultimately, treatment should be offered within an integrated, multidisciplinary treatment plan. You mentioned before the importance of teams. And then finally, identification and treatment of psychiatric disorders and symptoms can definitely improve the overall quality of life for individuals with ASD. I also wanted to mention that Marshall University has a multidisciplinary clinic for individuals with suspected autism spectrum disorder. It's a collaborative effort with individuals from the Autism Training Center, the psychology department, speech pathology department, occupational therapy, and even physical therapy that can be a resource. Within the Autism Training Center, we're also beginning to offer private evaluations for individuals with suspected or diagnosed autism spectrum disorder.